My name is Niels van der Donk from Amsterdam University Medical Center in the Netherlands, and I'm happy to discuss our oral abstract from ASH23 entitled Iberdomide Maintenance After Autologous Stem Cell Transplantation in Newly Diagnosed Myeloma, the first results from the EMN26 study. Here you can see my disclosures. So maintenance with lenalidomide is currently the standard of care after high-dose chemotherapy and autologous stem cell transplant, with improvement of response at 6 months of 26% and at 12 months of 31%. All patients remain at risk of relapse post-transplant, and between 24 and 29% of patients discontinue len maintenance due to adverse events or poor tolerability. So there is an unmet need for new agents with improved activity and tolerability in the maintenance setting. In this respect, iberdomide is an interesting new agent because it's an orally available, potent cereblon E3 ligase modulator with greater direct anti-tumor activity and also enhanced immune stimulatory effects compared with len and pom. It's also administered as an S isomer, and this may result in a better safety profile. Iber safety, efficacy, and pharmacodynamic data from the ongoing CC220 MMO1 trial justify further investigation of Iber in the maintenance setting. And at ASH we presented the initial results from the ongoing EMN26 phase 2 study with Iber maintenance after transplant in patients with newly diagnosed myeloma. Patients could be enrolled in the EMN26 study if they had newly diagnosed disease with at least a PR after transplant and were treated with PI plus IMiD-based induction treatment. Patients could receive 1 or 2 transplants with or without consolidation. Patients were enrolled in one of 3 cohorts with starting dose of Iber of 1.3 milligram, 1.0 milligram, or 0.75 milligram. And cohort 3 with 0.75 milligram was added much later, so follow-up of this cohort is much shorter. And this cohort was added to get a better impression on the efficacy and safety across a wide dose range to select the best dose of Iber for maintenance. The primary endpoint of this study was efficacy, defined as response improvement within 6 months, and key secondary endpoints were safety, PFS, and OS. Here you can see the baseline disease and patient characteristics. These were overall well balanced among the 3 different cohorts, with high-risk disease in 20% of patients and ISS stage 3 in approximately 1/3 of the patients. And here you can see how patients were treated prior to enrollment and their response at study entry. And you can see that in the Iber 0.75 milligram cohort that was added later, that a greater proportion of patients received a DARA-based quadruplet, 88%, while this was only 33% in the first 2 cohorts, illustrating how fast myeloma treatment is changing over time. And the higher rate of DARA-based quadruplets in the 0.75 milligram cohort translated into a higher rate of MRD negativity at study entry, 65% in 0.75 milligram cohort versus 50% in the other 2 cohorts. Follow-up was longer in the first 2 cohorts, 14.6 and 17 months versus 4.7 months. Few patients discontinued treatment, slightly more in the 1.3 milligram cohort, slightly more because of adverse events compared to the other 2 cohorts. Dose reductions were also slightly more common in 1.3 milligram Iber cohort compared to the other 2. However, the relative Iber dose intensity was approximately 90% in all 3 cohorts, so very high. Hematologic safety profile is shown in this table during the first 12 cycles for the first 2 cohorts. I'm not showing cohort 3 because it has a rather short follow-up, and this will be presented later. The major hematologic adverse event was neutropenia, slightly more common in the 1.3 milligram cohort, but this could be well managed with dose reductions and dose delays, and sometimes growth factor support. There was only 1 case of febrile neutropenia in the 1.0 milligram Iber cohort. Importantly, grade 3 or higher thrombocytopenia or anemia were not observed during the first 12 cycles in both cohorts. Non-hematologic safety profile is shown here. And what I can say is that Iber was well tolerated with few grade 3 or higher adverse events. There were no second primary malignancies. There were no cases of venous thromboembolism observed. Rash occurred typically during the first 1 or 2 cycles and was of low grade and could be easily managed. Here you see response improvement during the first 6 cycles, and we see 42% response improvement in the 1.3 milligram cohort, and it was 35% in the 1 milligram cohort. We also looked at MRD conversion from positive to negative, and the MRD conversion rate was 15% at 6 months in the 1.3 milligram and 24% in the 1.0 milligram cohort. And at 12 cycles, we see a further deepening of response, with response improvement in 50% and 54% in both cohorts, respectively, with MRD conversion also increasing to 58% in cohort 1.3 milligram and 29% in 1.0 milligram. Progression-free survival data are not yet mature. You can see that at 12 months post-enrollment, in both cohorts, there was 90% progression-free survival, but again, few events, 5 events in cohort 1 and 5 events in cohort 2. So we need longer follow-up. And that brings me to my conclusions. Iber maintenance results in an improvement in response over time in patients who received IMiD and PI-based induction with or without anti-CD38 antibody and transplant. And this compares favorably with len maintenance. Iber demonstrated at least 50% improvement of response in cycle 12, and this was 31% with lenalidomide in the EMN26 trial. So this compares favorably. And also the MRD conversion from positive to negative during maintenance that we observed with Iberdomide compares favorably to what has been described with lenalidomide. And of course, MRD conversion is an important outcome post-transplant because it translates into an improved progression-free and overall survival. Iber showed a manageable safety profile with few grade 3 or higher non-hematologic adverse events. And these data support the investigation of Iber versus len maintenance in the ongoing phase 3 registrational Excalibur maintenance trial. The design of this trial can be seen in this slide. In the Excalibur maintenance trial, there is a stage 1 where patients can be treated at 3 different cohorts of Iber, the same doses actually as we investigated, but also a control cohort with len-10. And this stage 1, together with our study, will inform us about the best dose of Iber for maintenance. And this dose will be selected for stage 2, where an additional 1,000 patients will be enrolled, and these patients will be randomized against either Iberdomide at the selected dose or lenalidomide as a standard of care. And this study will hopefully lead to a new, more effective and better tolerated maintenance strategy for newly diagnosed patients with multiple myeloma. And that brings me to my acknowledgements. I wish to thank all the patients who participated in the study, my colleagues, and all the staff that was involved in this study, especially Andrea Capra from the EMN for help with statistical analyses. I wish to thank the data monitoring board members, the safety monitoring board members, and also Celgene, Bristol Myers Squibb company, for financing our EMN study. And thank you for your attention.